Hello, I'm Dr. Sam Selby. I'm a pediatric ER physician at Cook Children's in Fort Worth, and I also work at the University of North Texas Health Science Center, TCOM. And I'm here today with two of my colleagues. We got Sharon Ode and Haley Wolf, and they are second year medical students who have been working with me on this quality intervention project. So we're going to be talking about inadequate post-intubation sedation and analgesia in the pediatric ED. Our other colleagues are Dr. Tyler Hamby, a statistician, and Dr. Ruthie Saina. She's a pharmacist in the emergency department at Cook Children's.
So now I'm going to move on into the background of our research. So let's talk about the problem. The patients that are intubated in the emergency department often do not receive additional sedation and analgesic medications within the duration of action of the paralytic given during the procedure. As a result of this, these patients are likely to experience ongoing paralysis without adequate sedation, and there can be complications associated with the stress of the inadequate sedation, and we'll go into the specific complications that can happen in the next few slides. To kind of give background into it, the intubation in the emergency department, in the cases that we looked at, a lot of the studies were conducted in adult populations. However, we did find cases that were happening in pediatric emergency departments as well. And in these cases, it showed that many pediatric patients do not receive additional sedation within an appropriate time frame, such as within the duration of action of the induction agent used during intubation. So one of the problems that we could see that might be leading to this is that the current process in the emergency department for intubation lacks standardization, which is likely to cause a delay of care. Looking at the process, initially patients are given an induction agent and a pre-medication, followed by a paralytic agent, and then the patient is intubated. However, when it comes to the post-intubation sedation and analgesia, what happens is that usually those medications aren't called in until a nurse or someone else notices that the patient has an increase in their heart rate, or they're showing signs of starting to move a little bit. And in that case, they call the provider and ask them to provide a bolus as opposed to an IV drip that they can keep getting the medications on, and that tends to cause a delay of the medications being provided to the patients. Going into the side effects that come with patients being inadequately sedated, what can happen is a patient can become aware during their paralysis, and that can lead to pain, anxiety, and agitation, which can then lead to changes in cardiovascular function, immune system function, stress response to injury, recovery time, and morbidity. And looking at the cases that we did see, it showed that adequate sedation decreases the chances for self-extubation, uncontrolled pain, and heart attacks. One of the problems that can be contributing to this issue is the fact that in many cases, providers are using a paralytic agent that has a longer duration of action and a sedative that has a shorter duration of action. Therefore, the paralysis typically outlasts the sedative effects of the induction agent, which can lead to patients' discomfort and awareness being masked. As such, it's really important that analgesics and sedatives be given early to avoid inadequate sedation while patients remain paralyzed. To kind of show the medications that are used, the duration of paralytics that were often used in the Cook Children's ED were rocuronium, whose duration of action lasts between 30 to 60 minutes, and the induction agents that were used, their duration of action tends to be shorter, around 10 to 30 minutes, as can be seen in the table below.
So moving on to the purpose. The purpose of this study is to determine whether patients intubated in the Cook Children's Medical Center Emergency Department are given adequate sedation and analgesia following intubation. So this project will help to improve patient safety, comfort, and outcomes, as well as to inform staff at the Cook Children's ED, as well as other pediatric emergency departments. So the Cook Children's Medical Center's Emergency Department is a 78-bed department with a level 2 trauma designation. And in 2022, their patient volume was 138,672 patients. So we completed a chart review for all patients that were intubated in the Cook Children's Emergency Department between June 31st and December 31st of 2021. We included all pediatric patients that were intubated there during this time, and we excluded patients who were intubated at another facility prior to arrival at the Cook Children's ED, as well as those patients who had incomplete charts. And so doing this, we looked at 113 charts in total and excluded 7 patients from the study. In this chart review, data was collected on the time that the patient was intubated, the medications that were given, and the time that each of those medications was administered. The primary outcome that was assessed in this study was the percentage of patients that received a sedative or analgesic within the duration of action of the initial induction agent used during their intubation. Other secondary outcomes that we looked at included the percentage of patients who received no induction medications before being intubated, as well as the percentage of patients who did receive an induction medication but did not receive any further sedative or analgesic medication after intubation. And finally, the percentage of patients who received no induction, sedative, or analgesic medications either before or after being intubated.
All right, so that's a good overview of kind of the background and the purpose of the study. Now let's look into the results. So a total of patients were intubated in the Cook Children's Medical Center emergency department during this time period. As mentioned, 7 of these patients were excluded because of our exclusion criteria. So that left 106 charts for us to analysis. And so this is kind of a breakdown of the patients as they fell into their different groups. If you'll look at the top line, this is the group that we were looking for. Hopefully, most of our patients are receiving a sedative and an analgesic medication prior to intubation, and then they're also getting subsequent analgesic medications within the duration of action of that medication so that they continue to get sedation. It looks like of the 106 patients that we looked through their charts, only 17 or 16% received this. I'm going to skip down to the line. And so this group received a sedative medication, but not within the duration of action of the induction medication. So you can imagine the nurse calling for that bolus to be given as a PRN medication because either the heart rate increased or the patient was moving. Of our patient population, 31.9% fell into this group. The next row shows patients who did not receive any additional sedatives or analgesic medications following intubation, and 42 patients, or 40%, were in that group. Next, we have patients who did not receive induction or pre-medications, so they might have been intubated without those medications, but they did get something shortly after intubation. Only 7% fell into this group. I'd imagine these were patients who presented in extremis that were needing an emergent airway, and we did not either have the time or the patient just needed that airway before the medication was given. And then the last row talks about patients who did not receive any medications before or after intubation. And most of these patients arrived either pulseless or getting CPR, and ROSC was not achieved. You can understand why they might not have received subsequent doses of analgesic medication. So again, the top row is our ideal. I think that for this study, we've shown that we could actually make a large difference in the second and third, and probably even the fourth rows here. So we could help give patients that subsequent analgesic dose or help providers get the analgesic doses on ahead of time as well. So let's talk about how we may do that. So as mentioned, most intubated within the Cook Children's Medical Center ED with the time frame that we looked at were not given a timely subsequent analgesic or sedative dose. And this is not something that's just unique to our facility. As we've seen in other studies, adult emergency departments are struggling with this, as well as pediatric emergency departments. However, we all understand that sedation is a priority for our intubated patients, and it's something that we are striving to make an improvement on. Other institutions have shown improvements in their post-intubation sedation and analgesia. Some of the measures they've implemented include checklists, education to the staff, changes in their electronic medical record systems, and other suggestions as well. The findings of our study are going to help to guide those education interventions and guide the changes that we're going to try to implement to make improvement in this area. So where are we at in our intervention overall? So step one of the process was to implement a post-intubation order set. So at Cook Children's Medical Center, we use Epic as our medical record, able to implement an order set that is going to be effective as soon as the patient comes in the door and we realize that they need to be intubated. Pharmacy, nursing, or physician can access this and order not only the initial medications for induction and intubation, but also drips as well. This order set is live, and that moves us into step two. So step two is actually a multidisciplinary education on the post-intubation order set and analgesia. We've kind of broken this down into a few different steps, and we're in the middle of this for our QI intervention. What we did was initially we built the order set and released it, and we let the providers know that the order set is live. The providers have been on their comfort level on using sedation medications in the post-intubation setting. They were given education on the need of why this is needed in our facility. The next intervention is going to be to give that same type of intervention to the pharmacists and nurses throughout the department as well. And then I anticipate we will move into step three shortly after, where we create and implement a RSI checklist that will include the post-intubation analgesia as well. So here's an example of that step three, where we will have the RSI medications and the checklist to kind of help us think through not only the medications that we need immediately for the intubation, but also what we anticipate having afterwards as well. This is not live at this point, but we anticipate rolling that out in the next few months. So there were a lot of people that worked hard on this project. I really thank Dr. Priya Bowie from UNT HSC, Dr. Basha, and Dr. Tyler, all who are over kind of the pediatric research program at TCOM. And then also my partners, Dr. Hamby and Ruthie from Cook Children's. And I also appreciate Haley and Sharon for their hard work on this project. And I'm excited for the way it's going to move forward in making improvement in children's life in our immediate region.